Good evening, all of you. Welcome to Pharmacology Last Minute Revision MCQ series brought to you by Unacademy. And the topic of this session is drugs used for treatment of arrhythmias. I am your pharmacology educator, Dr. Arpit Agarwal, and together, you, me, and Unacademy, we will crack NEET PG, FMG exam, and any other competitive exam. So let's begin. Who am I? I'm Dr. Arpit, MD in Pharmacology. I've been teaching pharmacology for over 10 years now, across the country and also abroad. I've mentored 50,000 students over the last decade who are preparing for pre-PG as well as the FMG screening examination. If you are the first time visitor to our YouTube channel, if you're watching this particular video for the first time, and if you have not yet downloaded the Unacademy app, then what are you waiting for? It's the best online learning app. Download the Unacademy learning app, enroll in the NEET PG or the FMG segment, and you will find for yourself how Unacademy, along with its educator, is going to help you crack all these examinations. Unacademy brings you the Plus subscription. With Plus subscription of Unacademy, you will get the daily live classes. You will get various courses which have been designed to suit the requirements of each student, whether you are preparing for NEET. So we have separate batches for upcoming NEET. We have separate batches for FMG examination. We have separate batches for the next. We even have separate batches for the upcoming INI CET examination. You will also get live tests and quizzes, and needless to say, everything comes with an unlimited access. You can also go for the iconic subscription, which will give you the best of two worlds. One is Unacademy, all live classes and batches. Along with that, you will also get the video recorded lectures of the prep ladder. So both will come with the iconic subscription. As I said, we have several very specifically targeted batches for each examination. So recently we have started for the INI CT 24-day MCQ marathon batch with 19 subject-wise tests, 3 grand tests, and rapid revision of the high-yield topics. So as I said, with Plus subscription, you will get access to these specific exclusive batches curated to suit your requirements with the best educators in the country at single platform. Similarly, recently we have started an FMG analysis batch on 7th of April. Along with that, it comes with subject-wise test, grand test, and rapid revision of the high-yield topics. Remember to use the code Dr. Arpit Agarwal. This is the code that will help you in unlocking the free classes and also give you a discount on the Plus as well as the iconic subscription. So you can choose. You can also choose the duration of your subscription as shown, and different duration would cost you different amount of money. The code Dr. Arpit will give you a discount also. This is our schedule for the last minute revision MCQ that we are doing on the Let's Crack NEET PG YouTube channel since 6th of April. And today on 10th of April, we already completed at 9 p.m. drugs for angina. And now we are going to discuss in episode 10 of last minute revision MCQ drugs for arrhythmia. So this is what we will discuss right now. So let's start. Let's begin. First question comes. Correctly match the anti-arrhythmic drug with its mechanism of action. So correctly match the anti-arrhythmic drugs with their mechanism of action as per the William Bones classification. Class 1, 2, 3 and 4. It is very simple to remember, to understand. What you do, you simply draw a cardiac cell. Okay, you simply draw a cardiac cell. This is a cardiac cell. And outside the cell, you draw a blood vessel. So this is a blood vessel. And in order to remember the classification, you just move from outside the cell to inside the cell. Okay, start moving from blood towards the cell. Now we know that in blood, that is extracellular space, sodium is the most important cation in extracellular space. So class 1 drugs will be simply sodium channel blockers. So class 1 is a sodium channel blocker. 1 goes with A here. Then from blood we come to the cell membrane of the cardiac cell. We find beta receptor there. Beta receptor are there. So we will meet beta receptor on the surface of the cell. Class 2 antiarrhythmic will block beta receptor. Beta blockers are class 2 antiarrhythmic. So class 2 is beta blocker. So 2 goes with C. Then inside the cell we find that the most important cation is potassium. So class 3 antiarrhythmics are those that block potassium channel. So class 3 antiarrhythmics are potassium channel blocker. So 3 goes with D here. And within the cell, there is an organelle, sarcoplasmic reticulum, that is filled with calcium. So you will encounter calcium at the very end, deep inside the cell. So class 4 antiarrhythmics will block calcium channels. So class 4 antiarrhythmics are calcium channel blocker. 4 goes with B. So this is the manner, this is the way to remember the classes of antiarrhythmic. Move from where? Outside the cell, inside the cell. From outside to inside, first you will encounter sodium channel, block it. Then you will come across beta receptor, block it. Then you will encounter potassium, block it. Then you will latest. In the end, you will encounter calcium, block it. 1, 2, 3, 4 classes. The answer to this question is this: A, B, C, D. So I'm looking for A, B, C, D. Option number B is the correct answer. Option number B is the correct answer. So I hope now it is clear how to remember the classes. How to remember the classes of antiarrhythmic drugs. Okay. Question number 1 is done. First question to begin with: how to remember antiarrhythmic classes. 1, 2, 3, 4. I have told. Next question. Antiarrhythmic drugs that prolong QT interval. Very, very important question. Antiarrhythmic drugs that prolong QT interval. So can you tell me which antiarrhythmics out of the names which are written on your screen? They include quinidine, ibutilide, lignocaine, propranolol. Which of them prolong QT interval? Yes, Prabhakar, Shayanta. So what you have to remember, antiarrhythmics that prolong QT interval are class 1A and class 3. There are two classes of antiarrhythmic that prolong QT interval, and QT interval is prolonged because of any drug that is capable of blocking cardiac potassium channel. So these are the two main classes which can block potassium channels in heart. Class 1A is remembered by Queen protects disco pyramid. Queen protects disco pyramid. That is the mnemonic of 1A. So I am looking for quinidine. I am looking for procainamide. I am looking for disopyramid. Class 1A drugs all prolong QT interval. So quinidine will prolong. Similarly, class 3 drugs can be remembered. The important examples will be remembered by the mnemonic AIDS. So class 3 include amiodarone with A. I stands for ibutilide. D stands for dofetilide. And S stands for sotalol. So these are the important members in class 3, can be remembered by the mnemonic AIDS. So ibutilide, which is mentioned here, will prolong QT interval. Lignocaine, please remember, is class 1B drug, and 1B drug, please remember, actually decrease QT interval. So lignocaine will not do it, and also beta blockers do not increase. So 3 and 4 will not. 1 and 2 is the answer. So option number D. Option number D is the answer. Option number D is the answer. Prabhakar will come to your query. Option number D. So please remember antiarrhythmics that prolong QT interval, class 1A and class 3. Queen protects disco pyramid and AIDS. Now please remember 1C drug. 1C, especially one molecule in 1C, flecainide. 1C have variable effect on QT interval, but 1C drug, flecainide, can also, if provided in the option, you will also use this drug as a drug that causes QT prolongation. So 1C generally do not have any significant increase, but flecainide from 1C, class 1C may increase QT interval. So just remember as an exception. Otherwise, you are looking for 1A and 3. I hope this question is clear. Prabhakar, you were asking about option of question number 1. So I hope 1C, D, B. That was a mistake. Here the correct option 1 is A, 2 is C. So this is the correct answer. This is the correct answer. Okay, I have written A, C, D, B. Okay, that is the correct answer. So thank you, Prabhakar, for pointing that out. The answer was written correctly here, but I wrongly marked it here. This question I have told you, now staying with QT interval, but we have a drug X which causes QT prolongation, but still the incidences of torsade de pointes is rare with it. What is drug X? So please remember, if QT interval, whenever QT interval or corrected QT interval goes above 450 milliseconds, then there is very high risk of developing a ventricular tachycardia known as torsade de pointes. But the question is asking that there is a drug which increases QT but does not lead to torsade. What is that drug? And that drug is option number D, amiodarone. Very good, Prabhakar. Very good, Shyam. That option is amiodarone, because amiodarone has many other action also. It has many other action. So what does it mean? Amiodarone predominantly class 3 drug, blocks potassium channel, and by blocking potassium channel, QT interval goes up. But in addition to that mechanism, this drug is also a sodium channel blocker. This also can block beta receptor, and this can also block some of the calcium channel. So because of the other actions that it has, the incidences of torsades is very little with amiodarone. So that is this unique drug, that it can increase QT but does not cause torsade de pointes. So please remember, torsade de pointes is absent, although QT prolongation can occur with amiodarone. Now that brings us to another question. If you are asked that drug of choice for torsades, what is going to be your answer? Yes, doctor. बताइए, drug of choice पूछ ली जाए for treatment of torsade de pointes, then what will you write? This is the kind of ECG that you get with torsades. A crescendo or twisting pattern of ECG is seen, polymorphic ventricular tachycardia. So you can see the crescendo pattern, QRS increasing, QRS decreasing, crescendo or twisting pattern. Twisting in French is known as torsade, hence the name. And Prabhakar is only one answering for this question. Correct, IV magnesium sulfate. IV magnesium sulfate is the drug of choice for acute management of torsade de pointes. So please, I will request all of you who are watching this session, to please participate, provide the answer Cyanthan, yes, very good. Magnesium sulfate. So QT prolongation we have discussed. Now we go to another MCQ. Very important. At high blood levels, an antiarrhythmic drug causes signs and symptoms that resemble salicylism. So aspirin toxicity is known as salicylism, that manifests as tinnitus, initially tinnitus, ringing in ear, visual disturbances. These are symptoms seen with aspirin toxicity or salicylism. Similarly, there is an antiarrhythmic whose toxicity also resembles salicylism. Which drug most likely caused? So this is a memory based question. Quinidine. Quinidine initial toxicity also presents with tinnitus and visual disturbances along with nausea and vomiting. So that resembles salicylism. Memory based question. So initial symptom of tinnitus and visual disturbances can occur with aspirin poisoning and also with quinidine poisoning. Remember, quinidine 1A drug. Yet just now I told you, if you give too much, it will cause prolongation of QT and dorsates. Another problem with quinidine, please remember, it is a derivative of quinine, dextroisomer of quinine. So like quinine, it can also cause synchronism. And like quinine, it will also cause the release of insulin and therefore hypoglycemia. So hypoglycemia is also possible with quinidine. Next, identify the antiarrhythmic to be avoided in patients with history of glaucoma. So why would any drug be avoided in glaucoma? First of all, we have to understand what is the common reason behind avoidance of any drug in glaucoma. What is asked in exam? What is the reason a drug should be avoided in patients with history of glaucoma? So please remember, commonly we want to avoid any drug which can cause mydriasis. Any drug capable of causing mydriasis is to be avoided because mydriasis can precipitate attack of glaucoma. And which kind of drug cause mydriasis? Any drug which has anticholinergic property. Any drug which has anticholinergic property is capable of causing mydriasis, and mydriasis will precipitate attack of glaucoma, angle closure glaucoma. So we would like to avoid anticholinergic drugs in patients with history of glaucoma. Now comes the question, which antiarrhythmic has anticholinergic property? So when we talk of antiarrhythmic with anticholinergic property, the class that comes to my mind is 1A. Class 1A, and in this class 1A, maximum anticholinergic property lies with disopyramide. Disopyramide has significant anticholinergic property, much more than quinidine. So maximum anticholinergic property lies with disopyramide, and therefore disopyramide should be avoided in patients who have history of glaucoma. Here 1A. Remember 1A, queen, protects, discopyramide. All of them have anticholinergic. Maximum lies with the disopyramide, minimum lies with procainamide. So disopyramide, remember, anticholinergic property and should be avoided in history of glaucoma. Quinidine. Now when it comes to quinidine, please also remember this drug also has some anticholinergic property, maybe not as high as disopyramide, but what is the question asked on anticholinergic property of quinidine? Due to anticholinergic property, it can cause increase in heart rate. Increase in heart rate will occur if you give quinidine alone in patients of atrial fibrillation, it will end up causing tachycardia, and this is known as paradoxical tachycardia. Paradoxical tachycardia. तो AF का पेशेंट आया जिसकी हार्ट रेट ऑलरेडी ज्यादा है एट्रियल फिब्रिलेशन में, 200-300 हार्ट रेट लेके आया, आपने सिर्फ विदाउट ब्लॉकिंग एबी नोड आपने सिर्फ क्विनिडीन दे दी, बिकॉज ऑफ एंटीकोलिनर्जिक इट विल कॉज फर्दर टैकीकार्डिया, पैराडॉक्सिकल टैकीकार्डिया. So anticholinergic property of quinidine, this question is asked. An anticholinergic property of disopyramid, this question is asked. So I hope this is now clear. Quinidine की property में क्या question आएगा और disopyramid में क्या question आएगा. So this is a very important slide. Please remember which antiarrhythmics where you will avoid. So procainamide I will start. Procainamide, please remember what we used to read, SHIP, SHIP. That means drugs which undergo acetylation. All of these drugs which undergo acetylation, sulfonamide, hydralazine, isoniazid and procainamide, class 1A drug, they can cause SLE, and one of the main symptom, important symptom in SLE could be arthritis. So if patient has history of arthritis, avoid procainamide. Glaucoma, avoid disopyramid, that also already been discussed. Amiodarone, we will see, causes pulmonary fibrosis. So patient having lung disease, avoid amiodarone. Verapamil always causes constipation. So if too much constipation history is there, avoid verapamil. Beta blocker, I hope by now everybody is aware, should be avoided in asthma, peripheral arterial disease and in diabetics prone to hypoglycemia. Avoid beta blocker. QT interval, if there is history of long QT interval syndrome, class 1 and A3 drug should be avoided. And remember, a class 1C drug, flecainide. This drug, you remember, should be avoided post MI. Why? There was a study known as cardiovascular outcome after ST elevation, CAST study. So in CAST study, it was done on MI patient. Those patients who received flecainide, they had greater mortality. So please do not give flecainide in patients with history of MI. So this is a very important slide. All important contraindications of various antiarrhythmic drugs is summarized. So you will never find any question on contraindications of antiarrhythmic besides this. Besides this table, you will not find a question. So you know, last minute revision, you need these kind of slides. You need these kind of concise information. Now we come to lignocaine. Lignocaine, please remember, is not 1A, it is a class 1B drug, and class 1B drug actually decrease QT interval, so there is no risk of torsade. This is one very interesting information that you should know. But the question is asking lignocaine toxicity, and that too early sign. Early sign of lignocaine toxicity. So now you have to remember two things here. Number one, lignocaine is not arrhythmogenic or not cardiotoxic. The main toxicity of lignocaine is neurotoxicity. The drug is neurotoxic. It is not cardiotoxic, number one, but it is mainly neurotoxic. So when the levels are low or reasonably not very high, slightly high, then you have nystagmus. You will have ataxia. These are some of the initial symptoms to begin with. This will later on be followed by tingling or paresthesias. And as the level goes on increasing, patient will develop seizure. So nystagmus is an early sign, seizure will come later on in the toxicity of lignocaine. So please remember, early sign is asked, early sign is nystagmus, seizure is not an early sign. Seizure के बाद तो सिर्फ कोमा ही है न्यूरोटॉक्सिसिटी में, तो seizure could not be, is not the early sign. Nystagmus, ataxia, paresthesias, these are early signs, seizure is a late sign. सीजर के बाद तो बचा ही क्या, न्यूरोटॉक्सिसिटी में, उसके बाद तो सिर्फ कोमा है। नेक्स्ट क्वेश्चन, a woman who has a large multinodular goiter. So large multinodular goiter is suggestive of hyperthyroidism. Now she develops atrial fibrillation. Which would be the best to treat this arrhythmia? Best to treat this arrhythmia. So patient has hyperthyroidism with atrial fibrillation. With or without atrial hyperthyroidism, answer would remain, I think, the same. Atrial fibrillation का treatment मैं आपको बता देता हूँ. AF number 1. There are two aims to the treatment. First is control ventricular rate. First aim of the treatment is to control ventricular rate, and for which we give AV node blockers. AV node blocking drugs are given. In AV node blocking drugs, I am looking for beta blocker. We are looking for verapamil, or we are looking for adenosine. Rarely, if the patient has CHF, we can also give digoxin. If the patient have CHF also present, otherwise no. So AV node blocking drugs are the first drug to be given to control ventricular rate in AF. Once that has been controlled, then you will control rhythm. So rhythm control, that is conversion of AF back into sinus rhythm, for which nowadays class 3 drug like amiodarone is the preferred, or you can use class 1A drug like quinidine also. But class 3 drug like amiodarone is the preferred. So first drug that is normally given in AF is always beta blocker. This patient also has hyperthyroidism. So beta blocker will provide symptomatic treatment in hyperthyroidism also. So propranolol being the best drug out of the given. So even if hyperthyroidism is not given, I think still answer will remain beta blocker. Beta blocker. Please remember, this is the primary aim, to control the ventricular rate, and then you go for rhythm control with class 3 drugs mainly like amiodarone. A patient of atrial fibrillation is placed on long-term amiodarone. I hope now it is clear. Treatment of AF already discussed. Amiodarone has a place. It is the best drug for rhythm control. What should be assessed periodically in order to detect adverse effect of this particular drug? So side effects of amiodarone have to be remembered, and that would help you in remembering what has to be periodically assessed or monitored. Blood triglyceride, audiometry, prothrombin time and ANA levels, pulmonary function test, and thyroid hormone status. So this is a very, very important. You will monitor what? Sayanthan says D, Prabhakar says D, that is correct. Three main problem you will remember with amiodarone. It says please check my liver function test, thyroid function test, and pulmonary function test. So these are the three things that you will monitor during amiodarone therapy. Number 1, what? Liver function test, because amiodarone can cause fibrosis of liver, or we can say cirrhosis. Fibrosis of liver is same as cirrhosis. Amiodarone can cause hypothyroidism, so we will monitor thyroid function test, and the most important problem of amiodarone is the pulmonary fibrosis, so you will monitor pulmonary function test. Amiodarone can also cause C. C stands for corneal deposits. So what also should be monitored is the ophthalmological examination, or slit lamp examination should also be done periodically. So these are the 4 important problems with amiodarone, and these things will be monitored during amiodarone therapy. Okay, so I hope that is clear. Okay, that should be clear. Also focus on ANA titers. ANA titers, if the question is saying ANA titers will be measured if the patient is having procaine-amide therapy. As I told you, the drug can cause SLE, so you will try to measure ANA titers. ANA titers. Okay. All toxicities are seen with the amiodarone. Latest pattern, multiple correct answer. Tell me now. I have already told you, but let's see if you can still mark it absolutely correct. All are seen with amiodarone therapy. I have told you pulmonary fibrosis is the dose limiting toxicity. Main problem which after some time you cannot increase the dose of amiodarone because of pulmonary fibrosis. Dose limiting toxicity. Corneal deposit, yes. Cirrhosis of liver, yes. Hyperglycemia, no. No hyperglycemia occurs. 1, 2, 3. Option number A is the correct answer. Yes. So all three, Prabhakar, Sayantan, Avinash, very good. Correctly answered. Now we have a patient who is manifesting life-threatening ventricular tachycardia following an acute MI. So patient had an acute MI, and post that acute MI, patient has developed life-threatening ventricular tachycardia. Which is the drug would be the best to quickly control this particular situation? Tell me which is the drug of choice for this situation. Amiodarone, digitalis, quinidine, lignocaine. Okay, so you see there are two confusion here, whether to go for lignocaine or whether to go for amiodarone. Now very clearly it is written in, if you see the Braunwald, the Bible of cardiology, lignocaine if given for post MIVT will cause asystole. So lignocaine nowadays is not preferred post MI. So what is preferred nowadays is amiodarone. So post MI ventricular tachycardia, nowadays you will prefer amiodarone. Earlier lignocaine was given, I am not denying, but nowadays it has been observed that with lignocaine there are cases of asystole after MI. So do not give lignocaine post MI nowadays. What is to be given? Amiodarone for ventricular tachycardia, especially if it is symptomatic or life threatening. Similarly, post MI, after MI, patient may also develop ectopic. Understand? Please try to understand. Patient may also develop ventricular premature contraction or ectopic beats. These are mostly asymptomatic. Mostly ventricular premature contraction and or ectopic beats. Mostly they are asymptomatic after MI. If they are asymptomatic, please remember no treatment is needed. Okay. So you have to understand post MI patient will develop many kinds of arrhythmia. Many kinds of arrhythmia patient may develop. Post MI patient may develop even ventricular fibrillation. Post MI patient may develop ventricular ectopic beats. Post MI patient may develop tachycardia, ventricular tachycardia. Treatment of everything is different. If patient has asymptomatic ectopic beat, सिर्फ ECG पे आपको ventricular ectopic beat दिख रही है, patient को कोई symptom नहीं है, कोई कुछ देने की जरूरत नहीं है, no treatment. Patient develops sustained ventricular tachycardia, amiodarone, and patient develops ventricular fibrillation, cardioversion. DC shock आप उसको तुरंत देंगे, cardioversion. So please look at the question. What is happening? Ventricular tachycardia is happening here. Amiodarone. Lignocaine पहले देते थे, कई लोग पुरानी किताबों में अभी भी लिखा है देते हैं, बट अब ये डीसी शॉक या डिफिब्रिलेशन आप करेंगे इसमें. मैं हमेशा यहाँ कंफ्यूज रहता हूँ. डिफिब्रिलेटर आप उसको देंगे, वेंट्रिकुलर फिब्रिलेशन. Now we come to adenosine. True statement regarding adenosine is Adenosine. Please remember adenosine. Adenosine causes again hyperpolarization. Hyperpolarization. Hyperpolarization of AV node. That is the mechanism of adenosine. So hyperpolarization होगा तो obviously it will decrease AV conduction. So atria to ventricular conduction goes down. That is the mechanism of adenosine. Potassium channel opener है. Drug of choice for PSVT. This is correct. Administered as rapid IV. Yes, this is true. Adenosine ka T half is less than 10 seconds. Very short acting. So you have to give it as rapid IV injection, rapid IV bolus. You cannot give it oral. You cannot give it slow IV infusion. Very short acting drug. Avoid in asthmatic. That is true. Now this is very interesting. You see adenosine. Adenosine acts on adenosine A1 receptor. Now these A1 receptors are present in lung and adenosine causes bronchoconstriction as the side effect. So acting on A1 receptor in lung, it will cause bronchoconstriction. So therefore you will avoid an asthmatic, and that is true. And then you need to remember that the drug theophylline. Theophylline is simply an adenosine receptor antagonist. That is one of the mechanism of theophylline. It blocks adenosine receptor and therefore theophylline is used as a bronchodilator. So theophylline will decrease its therapeutic effect. This is also a true statement. That is also a true statement. Disopyramide increases. That is a false. That as disopyramide has got nothing to do with adenosine. So 1, 2, 3 and 4. 1, 2, 3 and 4. Option number C is the correct answer. So answer not all. Now why you got confused is, let me tell you. You are reading disopyramide but you are thinking of dipridamole. So please remember there is a drug known as dipridamole. Dipridamole nowadays is used as antiplatelet, and please remember dipridamole inhibits, decreases adenosine uptake and adenosine action goes up. So which drug increases adenosine? Dipridamole. But what is question saying? Disopyramide. Disopyramide. So please you have to understand dipridamole increases the action of adenosine and theophylline decreases the action of adenosine. Disopyramide has got nothing to do with adenosine. Okay? तो दो ड्रग इंटरेक्शन है. डिप्रीडामोल बढ़ाता है एक्शन, थियोफाइलिन कम करता है एक्शन. एक साइड इफेक्ट है ब्रोंकोकॉन्स्ट्रिक्शन और एक यूज है पीएसवीटी. So that is why you see Sayantan, the question has been put to clear the confusion, disopyramide versus dipridamole. Drugs which are implicated in development of heart block include which of the following? So which of these drugs will cause heart block, or you can say block AV conduction? Which of these drugs? Tell me. Simple question. Which of these drugs block AV conduction? Disopyramide will also decrease therapeutic effect due to anticholinergic action. देखिए एडिनोसिन का एंटीकोलिनर्जिक से कोई लेना देना नहीं है. एडिनोसिन अलग सब्सटेंस है, एंटीकोलिनर्जिक अलग सब्सटेंस. बीटा ब्लॉकर डिक्रीज. Lithium, please remember, decreases, blocks AV conduction. Adenosine, I just told you, and so does digoxin. 1, 2, 3, 4. Atropine is anti-cholinergic or anti-vagal. It will actually increase. It will actually increase AV conduction. So cholinergic drugs decrease and anticholinergics increase. So 1, 2, 3, 4. Option number A is the answer. AV node blocking drug. AV node blocking drug. So ये आपके पास एडेनोसिन which I have told you drugs causing AV blockade. ABCD main drug का फॉर्मूला है ABCD. उसके अलावा lithium or class 1 and 3 antiarrhythmics may also cause, but they are not very commonly asked. Now we have a question. We have a question of sinus bradycardia. So this is bradyarrhythmia. Okay. Generally, when we say arrhythmia, we mean tachyarrhythmias. Please understand, if you want bradyarrhythmia, patient or examiner or student to understand, you have to write bradyarrhythmia. Patient is developing bradycardia here, heart rate is dangerously low. Which drug would be the best choice? This is always the same. Only one drug we give for bradyarrhythmia commonly, sinus bradycardia or bradyarrhythmia, which is the best choice. Best choice for bradyarrhythmia. There are only two drugs for bradyarrhythmia. The best drug is always atropine. That is the best, most effective drug. And second option is isoprenaline. Isoprenaline is the second option that we can give. So best here is atropine. Even the advanced cardiac life support guideline will tell you atropine is the best drug. So that is all we had in this session, this episode of last minute revision MCQ. So we have discussed all important antiarrhythmics, quinidine, diazopyramide, beta blockers, amiodarone. We even discussed adenosine and we discussed drugs for bradyarrhythmias. So please block your calendars for the upcoming session. And what do we have upcoming? We have a very important session tomorrow, 10 a.m. and this is going to be on Unacademy app. So complete recap of pharmacology MCQ of all exams, AIMS, NEET, INI-CET, FMG of 2020. So if you are the first time visitor, have not yet downloaded the Unacademy app, do it and use the code Dr. Arpit Agarwal. This will help you to unlock this free class. This is a free class and you have to unlock if you are the first time downloader of the app. Okay, so 10 a.m. tomorrow, Sunday, we will begin by this very extensive recap of Pharmacology 2020 MCQ. So that is again, we have come to end of episode 10 of the rapid or the last minute revision MCQ. 10 episodes have been conducted starting 6th of April. So if you have missed on any of these, please watch them. They are available on your favorite YouTube channel. Let's Crack NEET PG YouTube channel. Tomorrow I'll be back at 9 p.m. with drugs for hypertension, followed by 10 p.m. drugs for renin, angiotensin, aldosterone system. So mark your calendars for 9 and 10 p.m. tomorrow also. So please remember these timelines. And if you have not yet downloaded the Unacademy app, do not waste any further time. Go to Play Store, type Unacademy and download the Unacademy learning app. You can enroll then for NEET PG or FMG segment and you will have the best educators to help you. Okay, so use the code Dr. Arpit. Use this code Dr. Arpit Agarwal to unlock the free classes, and also gain a 10% discount on your subscription. So that's all in this episode. I'll be back tomorrow at 9 p.m. with another episode of the last minute revision MCQ. Till then, it's goodbye from my side and enjoy